Good afternoon, everybody. Thank you for joining us at OHA for this COVID-19 healthcare provider webinar series. Today is the third, and I'm joined by my colleagues, Dr. Tom Jeanne, Dr. Ariel Smits, and Dr. Joe Sullivan. It's been almost a month since we've done one of these webinars, and there is a lot of new information. We are also trying out a new technology so that we are joining you safely, not all located in one room, and we're hopeful that this works out. So we'll be keeping an eye on if there's any technology troubles, but we'll look forward to bringing this to you in a new way today. Next slide, please. We do have a lot of information to cover, so we're going to try to keep on pace as well as try to incorporate answers to your questions where possible. We're going to briefly start out with an epi update as usual. Also just give you a glimpse of what's happening on regarding influenza. And then we'll dive more into sharing some new information about Oregon's risk and protection framework that the governor announced last week. We'll give you a COVID-19 vaccine update. We'll briefly cover monoclonal antibody therapies that have received EUA approval, and talk to you about the new CDC quarantine guidelines, followed by a brief review of Ms. A and other literature review if time. So next slide, please. So to start with our COVID-19 update, this is data as of yesterday, and needless to say, over the last month since we joined you, there has been a remarkable rise in transmission of SARS-CoV-2 in our state. And as related to that, of course, a large increase in the number of cases and unfortunately deaths in our state. So as of yesterday, we had over 78,000 total cases that we're reporting, 4,745 hospitalized cases total since the beginning of the pandemic, and very sadly now over 950 deaths. You can see all of this represented in the epi curve behind you. Just as a reminder, these bars represent the number of cases based on the date of onset of symptom or test positive if they were asymptomatic. The blue bar in the bottom represents those cases that required hospitalization, and the gray area in between shows where we yet are still collecting the data on hospitalization, knowing that that is a lagging indicator. Next slide, please. Looking a little bit more about the situation in Oregon, this is data based on our weekly report that we produce every Wednesday. So looking back at the week of November 23rd to 29, we had over 9,000 new cases recorded. This was up 5% from the prior week and represents the 6th consecutive week of record highs. Our hospitalizations have also increased to another record high, and sadly, 86 Oregonians died in association with COVID-19 during this week, reported here. We also are continuing to report test positivity, but we have changed the methodology for which that is reported, and that was covered in a recent press conference. Our test positivity for the week starting November 22nd was 8.6%. Next slide, please. As we've noted, the changes in our epi curve, we're also noting similarly a rise in sporadic cases represented here in that blue line, really outstripping the rest of the epi linkages that we're seeing at this time. And again, just really representing broad community level transmission. Next slide. And as we've spoken to many times before, we continue to see significant disproportionate impact by race and ethnicity in our state, with really notable disproportionate impacts to our Pacific Islander populations. I'm trying to catch back up here, our Black population and many beyond here that you can see represented here. If you look at our trend lines in the weekly report, the largest increases in cases have been among those who identify as Caucasian, but the disproportionate impact remains large and notable as represented in these data. Next slide. One of the other things that we are closely monitoring as we see the increase in transmission in our state is the impact to our hospitals. You've seen this covered likely in a lot of the news, and here is just really the remarkable statewide trends in COVID-positive hospital census. So the top line represents the number of patients on any given day across our Oregon hospitals that they report to us are COVID positive, and just really substantial increases over the last month. You can also see the upward trends of those patients who are requiring intensive care in that middle line, and a more moderate uptick in those requiring ventilators. Overall, this is definitely starting to stretch our hospital capacity, primarily due to some of the challenges around staffing the beds that we have to support the needs, not only of COVID positive patient, but all the other health conditions. There's no concerns at this point about ventilator access, but lots of hospitals starting to reduce their elective surgeries and try to repurpose staffing to support the inpatient critical care and medical surgical care needs due to staffing constraints and this substantial rise in COVID positive cases. Next slide. You can see by region that it's really being felt across the state, these increases. Certainly we have the largest population and number of hospitals in our Portland metro area as outlined in this blue or region 1 data here, but we're seeing rise in COVID positive patients really across the state. We continue to check in with hospitals across the state multiple times a week to assess and understand what the hospital constraints are and learn all the steps they're taking to be able to support all the needs that they of the patients in their hospitals at this time. So next slide, that gives you a brief overview of what's happening with COVID in our state right now. I think some fortunate news is that influenza remains being a minimal impact at this point. So looking at this data that I'm showing you, this is the most recent weekly data from November 15th to the 21st. And if you look at that second line there showing the percent positive influenza tests, we're at 0.2%. It's a really small number of tests coming back positive for influenza. Fortunately, since we are seeing so many COVID-19 associated hospitalizations, this at this moment is not causing increased constraints. So if you look at the next slide, this just gives us a quick look at the tests from the week of November 15th to the 21st. There was 5 positive tests. Interestingly, they were all from the Columbia Gorge region, in total representing just 0.2% positive tests out of the over 2,500 completed. And you can see that the majority of those were for flu B. And this is being consistent with what we're seeing nationally in terms of flu activity. It remains quite low. The next slide just gives you a glimpse of where we're at with regards to immunizations. We saw a notable peak beyond what we've seen in other years for flu vaccines. Uptake as reported in the Alert Immunization Information System. However, I will note that starting in late October, the weekly totals for new influenza immunizations really are starting to match prior season totals. We're not seeing that higher rate at this time. We now currently have almost 1.5 million influenza immunizations reported to Alert as of the week of November 21st, or ending the week, ending on November 21st. Okay, moving on. I'm going to pass this to Dr. Jeanne to talk about our new risk and protection framework. Dr. Jeanne.
Thanks. So yes, this is our new framework, which I'm going to say a few words about. This is really our general county metrics going forward. So as of today, the 2-week freeze in the statewide freeze that the governor had announced due to our surge in cases is over. And this new framework, which was announced last week, is really taking the place of both the freeze, of course, because it's over, but also the previous kind of phasing system we had. We had counties, we had a baseline phase and then phase 1 and phase 2 for different counties. We also had a statewide watch list that was separate from the phasing. So the new framework is really trying to simplify things and have just one framework with kind of a simple, although large, table for each sector based on risk levels. And it's recognizing that we've learned more about the factors that contribute to the spread of COVID-19. And so now we can try to create guidelines that better link sectors and activities to the level of risk that's associated. Let's see, let's go to the next slide here. So this is the main table in terms of the metrics. So there really are 2 metrics for each county, and you'll see 3 here because there's a separate metric for cases depending on whether the county is large or small. So counties with more than 30,000 people have that top one, the case rate per 100,000. And you'll also notice this is now over 14 days. And this aligns with our new school metrics that were announced at the end of October. And so these numbers are actually identical to the school metrics. So that's another way that we're trying to harmonize and simplify here. So by switching to a 14-day period, we are smoothing out some of the inherent variation that you'll see, especially in smaller counties from week to week. But even though it's a 14-day average, we still look at it every week. So we'll have new data every week that's posted typically on Mondays on our website. So you can see 4 risk categories here, lower risk up through extreme risk. And as I mentioned, that first row is the case rate for large counties. For small counties, the second row is just the absolute number of COVID cases over those 14 days, recognizing that, in a very small county, because their denominator of population is so small, just a handful of cases can lead to a very high case rate. So we think it's more appropriate and more practical to have that's the absolute number for small counties. And then finally, for most counties, there's a second metric, which is the percentage of test positivity, again, over the previous 14 days. There actually is an exception now for counties less than 15,000 people. It was decided that they would not be subject to this separate metric. But for all counties over 15,000, which is the majority, I think there's only 8 that are under 15,000, they do need to meet the percent positivity metric as well. And just a brief note that we did change our method for calculating percentage of test positivity recently. We had previously used a person-based test positivity metric, which made a lot of sense with our system early on in the pandemic, but in recent weeks, we've really seen that diverge from a test-based calculation. And there's a lot of reasons for why we chose what we chose. Actually, both person-based and test-based positivity calculations are recommended by CDC, but we have switched to test positivity based on tests. It was a bit of work, but this is actually going to lower it has lowered the test positivity for counties. And there was a question about whether that's retroactive, and yes, I believe that was retroactive. Okay, so that's kind of a lot here, but we basically got cases as an indicator of spread, and we have test positivity, which is also an indicator of spread or prevalence, as well as the adequacy of testing. So based on those 2 metrics for each county, or 1 metric for the very small counties, the county will be each week assigned one of those 4 risk categories. Let's go to the next slide. This is just a map showing as of Monday where the state was, and you can see we've got 25 counties in red in extreme risk, and that's reflecting the surge that we've seen nationwide. There are 4 counties in green, and then 1 or 2 in moderate and 5 in high. So we are within the framework, of course, here, but we're really hoping that over coming weeks, we'll start to see perhaps a bit of a decline, at least in some counties. But you can check this map. It's on the website, the link that was provided, and this is updated every week. You can see where your county is. Okay, finally, let's go to the next slide. And this is really what the sector chart, and this is just an excerpt. It's a chart with a lot more rows than this, but you can see again those 4 risk categories. So depending on where your county is, that will define where each activity or type of sector where they are and what their restrictions are. So you can see, for example, at the top here, we've got social gatherings. Social gatherings have been identified consistently as one of the major sources of outbreaks and COVID transmission. So we've got some pretty strict limitations there on the number of people and the number of households in different settings. And it goes on down for eating and drinking establishments, restaurants and bars. And you can see there's, for most of these sectors, we've got absolute limits with a total number of people. And we've also got percentage capacity limits in some cases. For restaurants and bars, there are some new closing time limits that vary based on the risk, as you can see here. And then just a note about the extreme risk category, it generally is pretty similar to what was in place for the freeze, but it's not identical. And you can see that for extreme risk and eating and drinking establishments, for example, there is outdoor dining allowed, and it was not allowed during the freeze. So again, this is the new framework. It's really designed to simplify. We hope that it's going to be a little easier to understand and a little easier for counties and for businesses and communities to really anticipate where they may need to go. And one additional note, counties are not required to if a county drops to a lower risk level, the county may choose to remain in a more restrictive risk level if they think that's important. There are some other sectors that I'll just briefly mention. We've got indoor and outdoor entertainment and recreation, retail, including grocery stores and malls, faith institutions, including churches. There's office guidance, and outdoor recreation entertainment. And then finally, personal services and long-term care. And for personal services, just a brief note about that, we had previously, during the March stay-home order, personal services like haircuts, physical therapy, things like that were actually not allowed, but they are completely allowed during every risk level here. And that's a recognition that we haven't seen spread from those. They tend to be one-on-one. They tend to be pretty low risk for spread. So have a look at this, and I hope that's a good overview for you all.
Thank you, Tom. I think if we can keep going, we're going to pass this off to Dr. Sullivan for a vaccine update. Thank you.
Good afternoon, everybody. It's my pleasure to kind of go over what's happening in the vaccine world and what's coming for Oregon. So I want to start with just looking at the two mRNA vaccines that are currently being reviewed for an EUA approval for the FDA. As you know, they're both mRNA vaccines that code for the spike protein. Their dosing schedule is slightly different. The Pfizer vaccine is 2 doses, 21 days apart, and Moderna 2 doses, 28 days apart, but they're both phenomenally effective. 94 to 95%. If you recall from our last conversation, the FDA had set a bar that the vaccines to be considered for EUA had to at least be 50% effective. So, and considering sometimes our flu vaccines are in the 40 to 50% effectiveness, this is phenomenal. They're both quite effective. And again, these numbers are not peer-reviewed numbers. These are from the manufacturers, and these are from press releases, but currently they're being reviewed by the FDA and ACIP as we speak. But they're both phenomenally effective, and what they looked at was prevention of symptomatic disease. And the vast majority of the cases in both of these trials were in people who got the placebo. And more importantly, or as importantly, I should say, the vast majority of those people with severe disease were in the placebo group. Pfizer did have one person who required oxygen, and we'll know more details coming up when that data is actually released. But the Moderna vaccine had 30 cases of severe COVID disease and 1 death, and all were in the placebo group. Both vaccines seem to be very effective in the older age group, and Moderna didn't break it down by ages, but they said that there was no difference in effectiveness by age, race, or ethnicity. And the big difference between the other big difference other than dosing schedule is the terrible ultra cold transport requirement by Pfizer. And that, I will tell you, is the biggest headache at OHA in trying to plan this, this rollout of these vaccines. I want to talk to you about, let's go to the next slide. I want to talk to you about the other vaccine that's on the horizon. And I know it's not in for an EUA yet, but it will be probably this month. And so this is a different platform. This is a different way of working. It's a non-replicating viral vector vaccine. People call it the AstraZeneca vaccine. And basically, it adds DNA that codes for the SARS-CoV-2 spike protein into a weakened cold virus. This is a chimpanzee cold virus. And what they've done, the genetic engineers have removed the ability for this virus to replicate and replaced that with the DNA code for the spike protein. So again, this virus is effective at getting into cells, hijacking the cell mechanism to make the spike protein, but not replicating. So what we saw was a press release on a phase 3 trial, an interim analysis that had 131 cases. Now these were in 2 sites, studied in 2 sites. The UK had about 3,000 and Brazil had about 9,000. And it showed an average efficacy of 70%. And many of you read about the fact that there was an error in the dosing regimen in the UK participants, that they only got half a dose of the vaccine at the first dose and a full dose of the vaccine the second time, whereas in Brazil, they received 2 full doses. It turns out that the efficacy was quite remarkably different, and 62% in Brazil and 90% effective in the UK. And so how that all gets analyzed, we'll have to see how it goes. The important thing was, or a number of important things, there were no hospitalizations or severe cases of COVID-19 in participants who were given the vaccine. So while it wasn't 95% effective like the mRNA vaccines, it was effective and it did prevent severe cases. Furthermore, they said that no serious safety events related to the vaccine have been confirmed, and it seemed to be well tolerated across both dosing regimens. It's also a 2-shot series, about 28 days apart, and one big advantage is that it's stored in a refrigerator. Next slide. There are some really interesting things about this trial that I want to bring up. The AstraZeneca did not use symptomatic disease as their endpoint, like the mRNA vaccines. They used weekly swabs, and I gotta say, God bless these participants who were willing to do this, weekly swabs to detect infection. Again, the mRNA vaccines looked at people who were symptomatic. So the AstraZeneca endpoint may be better for determining the ability of this vaccine to stop transmission. And I think where its strength is going to be is in this point. Now, I don't know if the new AstraZeneca trial that's going to be going on for the vaccine that's rolling out here in Oregon is using these nasal swabs, but it's really an interesting thing, and it'll be part of the FDA analysis of this vaccine. The second thing that was different is they used a meningitis vaccine for the placebo in the first immunization versus saline. And in the mRNA vaccine, they used saline, and they wanted the person who got the placebo to feel like they actually got a vaccine. One of the remarkable things about AstraZeneca is that they committed to not making money off of the coronavirus epidemic. So they are costing this vaccine at $3 to $4 a dose versus $20 to $30 a dose for the mRNA vaccines. This is really important for the rest of the world. From an equity standpoint, this is hugely important. But also because this was a less expensive dose, the US government has pre-purchased many more doses of the AstraZeneca vaccine than the mRNA vaccines. I do have to point out that this trial was paused twice, in July and September, for 2 volunteers who reported neurologic symptoms. And the investigators unblinded the study, they paused it and unblinded the study, and they found no link to the vaccine. But this is something that will be critically reviewed at the advisory committee to the FDA and the CDC. But like the mRNA vaccines, otherwise the AstraZeneca reported no serious adverse events. Let's go to the next slide. So what's our timeline? So as you know, Pfizer and Moderna have both submitted for their EUA, and AstraZeneca will likely do it soon. So what's the process next? So the Vaccines and Related Biological Products Advisory Committee, the VRBPAC committee that advises the FDA, meets on the 8th, 9th, and 10th to review the Pfizer application, and will come out with its recommendation at an open meeting on the 10th. They'll also release their data. I believe they said they would commit to releasing the data from the manufacturer on the 8th, so 2 days prior. The meeting for the Moderna vaccine is December 17th. And they have been committed, as have the other advisory committees that I'm going to talk about below, to move relatively quickly once an EUA is approved. So the next committee it goes to is the Advisory Committee on Immunization Practices, ACIP, and it advises the CDC like how to use this vaccine, where it's safe, who you can use it in, and so forth. And then finally, in Oregon, we're part of a Western States Scientific COVID Vaccine Safety Work Group, and it will concurrently be looking at the data to make its recommendation to the governor. But all of these safety steps have to occur before vaccine will go into an arm here in Oregon. So the Pfizer vaccine is scheduled to be shipped out December 15th, and the Moderna vaccine as early as December 22nd. I made an error there. Next slide. And I should say that this is obviously based on approval of the EUA. So the government has purchased about 100 million of each of the mRNA vaccines and 300 million of the AstraZeneca vaccines. And the manufacturers have given timelines about the number of doses that they think that they will be able to produce in the next several months. And the bottom line is that if things go as expected, and if there is good vaccine uptake, and then we would get through the 1A, B, and C, actually priority group, by the end of March. I will tell you, in trying to plan this, help plan this program, there are going to be a lot of bumps in the road. It will not go as smoothly as this, but this is optimistic in that we can expect a lot of vaccine to be coming to Oregon to get started to end this pandemic. Other things that might change the timeline: AstraZeneca is likely to apply for the EUA this month, and either it will get reviewed this month or more likely in the first week of January. And so having a third vaccine in the mix may be really helpful. And the AstraZeneca vaccine may have a special place in Oregon, in that this may be an effective vaccine for young people. If we can look at how it prevents transmission, this may be a great vaccine to roll out, and we may look at a different prioritization when a new vaccine comes in on board. The Janssen vaccine is also a non-replicating viral vector vaccine, and it's going to have its early readout probably in early January, and they will likely be applying, if they have good results, for an EUA at the end of January. Okay, next slide. So who's going to get it? This is a question everyone asks, and it's, this is based on ACIP's work, and they met on Tuesday. And what they've recommended, and I think what Oregon is moving towards, is that frontline workers and staff that are based in hospital, as Dana so rightly pointed out, how dire the bed situation in hospitals are and the staffing situations, we realize that this is a critical population to keep working. But when we talk about frontline healthcare workers, we're also talking about not just doctors and nurses, but people who cook the food, greet the patient, transport the people. All of those people are considered frontline workers and will be prioritized as such. Obviously, EMS providers who care for patients, but also the ACIP recommended that residents and workers in long-term care facilities and congregate care settings also be considered in this 1A group. Now, their vaccination is going to be handled by a federal pharmacy partnership with Walgreens and CVS. And what will happen is we will be allocated the vaccine and we will turn it over to our pharmacy partners, who will then go in to vaccinate in our skilled nursing facilities, our congregate care settings, to vaccinate both the workers and the residents. And then after that is when I think we would see vaccinations for outpatient staff. And I have to say that if there was enough vaccine to do everyone in this 1A group at once, we certainly would. And having to prioritize in this way is really difficult. We know that people who work in outpatient settings put themselves at risk every day. But I would just beg your patience and realize that we're talking about a number of weeks, not months, of difference between when the first people get this and the last people in this group will get this. And that just understand that with a limited supply, we're having to make some very, very difficult decisions. So the vaccine is not to be given within 90 days of a known COVID infection. And this is new recommendation from ACIP. All right, let's go to the next slide. So how many are we going to get, and when do we get them, and what's going to happen? So the government decided to distribute it on a pro rata basis, and so roughly Oregon is about 2% of the US population, so we get about 2% of the available vaccine. When we look at what is estimated that we will get, and you consider both the Pfizer and the Moderna vaccine, again, assuming that they are approved for their EUA, that Oregon will get enough vaccine to fully vaccinate over 100,000 healthcare workers and their staff. So when I say that, I mean that that's 200,000 doses of either the Pfizer or the Moderna vaccine will be coming to Oregon in December. Now, clearly, we won't be able to vaccinate all those people. Number one, there's a waiting period between the first and second shot. And number two, a lot of the vaccine that's coming to Oregon in December will come at the end of the month, right before New Year's, in fact. And so clearly will extend into January. Now, this number is inadequate to cover all the healthcare workers in the 1A group, and that's why I talked about prioritization above. That initially we'll work with the hospitals, and then the long-term care facility residents and staff, and then the outpatient providers and their staff. This next line, I said most, if not all, hospitals will receive the Pfizer ultra cold vaccine. That may not be true as of an hour ago. As we found out, we may be getting more Moderna than we thought. So it may be that more Moderna goes to more rural areas and more difficult to get to areas that don't readily have ultra cold storage. We are developing a hub and spoke distribution method. However, there are some existing ultra cold freezers in Oregon that we're going to use as a depot, and then in a storage place that smaller hospitals and hospital systems can use to draw off a certain number of vaccine. And we are purchasing, I think, 15 ultra low temperature freezers that are small, and many of which are mobile, that can be brought out into communities. And this is being developed as we speak. Still a lot of moving parts, and I just ask for your understanding. Let's go to the next slide. Right now, our work is signing up providers. And what I mean by providers is people who are going to give vaccine. So our most important group right now is getting hospitals signed up because that's where the first group are going to be. And the other reason we elected to use hospital workers as the first group is that they will allow for great throughput of a lot of people in one place with an occupational health department and who's already done vaccines for other things. And so we're trying to sign up all the hospitals, and we're nearly there. And then the next group will be larger clinics and health systems around the state and pharmacies. And then once you've signed up as a provider, we're having twice weekly vaccine office hours to ask questions, to help with your application and that sort of thing. And the information is here below. We also have a provider website on the OHA website that I've linked below, so that if you have questions about that, or how do I sign up as a provider, if you're in a small office and you want to sign up as a provider, you certainly can do that. Please understand that right now it's a bottleneck to get everything through. It is like a 3-step process, and so it does take a little time. So go ahead and start your application, but understand that the enrollment process may take a little bit of time. Let's go to the next slide.
Hey, Joe, before we keep moving forward to the next topic, I want to tackle a few questions that are coming our way, and maybe I'll start with some vaccine questions and then go back just a little bit on some other topics that we got some questions generated. So I know you have a couple slides here for references. As a reminder, these slides were all going to be posted on our healthcare provider COVID-19 webpage. So if you want access to any of these links or slides, please go back. But a couple questions for you, specifically, Dr. Sullivan. Can you speak a little bit more to Walgreens and CVS and their role, and is it just those two pharmacies? And then can you also maybe talk about whether or not, there was a question about whether or not people would need to get an antibody test before getting a vaccine. Let's start with those questions.
Yes, so the Walgreens and CVS have signed an agreement with the federal government, but to provide vaccinations for residents and workers in long-term care facilities and congregate care settings, and that's nationally. Other smaller pharmacies have the opportunity to sign up for this program, and one pharmacy that works regularly with long-term care facilities, Census, I believe, here in Oregon, has signed up as well. So there may be others in smaller locations that sign up that I'm unaware of at this time. As far as the antibody test, there's no need or requirement to do antibody testing. It would slow things down and be very expensive. And as you know, there's oftentimes false negatives and false positive tests that make it unreliable. And so I would think the only precaution would be if someone had a known COVID-19 episode within 90 days, I would not recommend the vaccine, but otherwise there's no pre-testing prior to vaccination.
Thanks, Joe. I want to just, I know there was a question about jails and prisons and other congregate care settings, and I think just know that there is a tremendous amount of more work doing to address so many of the detailed questions underway, and I don't think we'll have answers for all of them today, but please know that this is an area of rapid development and we will keep pushing out information. Do visit the office hours that Dr. Sullivan mentioned and keep an eye on our website. But just for the amount of more information we've come in, I want to stop and ask a couple other questions. These I'm going to focus on Dr. Jeanne, looking to you to ask. So first, we saw a question about masking and what is some clarification about when masks are required, particularly outdoors. And then another set of questions about the change to how we calculate test positivity and whether we are applying that retroactively to old test positivity data that we reported or just moving forward. If you could tackle those questions.
Yeah, so the question about wearing masks outdoors, I totally understand that question because there was originally a statement about, where 6 feet of distance can't be maintained outdoors, you need to wear a mask. According to the new guidance, it looks like it's just been updated today. Technically, masks are indeed required basically anywhere when you're not at home, if you're not in a personal vehicle, and if you're going through a drive-through or you have your window down at a gas station, you need to have a mask on, but otherwise you don't in your own personal vehicle. If you're under 5 years of age, if you're eating or drinking, if you're doing some activity that makes wearing a mask really not feasible, such as taking a shower, when you're sleeping, when you're in a private individual workspace, so that would be an office, your own office with walls and a closed door. And then the only other exception would be if you're, have to have your identity confirmed by visual at a bank or something, or law enforcement. So basically what that means is you need to be wearing a mask whenever you're in public at all, whether it's indoors or outdoors. So I hope that clears that question. Regarding positivity, Yes, I mean, my understanding is we had retroactively done the new test-based calculation for all counties. I'm not sure how far back that goes in all of our data that's published, but anything that you're seeing right now, I believe it's all been updated. I know it was a kind of a one to 2 week transition period that I think we're nearing the end of. So if you're still confused by the numbers this week, I think by next Monday, the county numbers will certainly all be the test based for every county and even going retroactively.
Great, thanks, Dr. Jeanne. I saw a quick question about influenza testing. I just want to remind you that we do have guidance on our website, clinical considerations for influenza testing during SARS-CoV-2 pandemic, recently updated on November 24th. I'm going to keep us going right now, but please do visit that guidance should that be helpful to answer your questions on influenza testing. Dr. Sullivan, I'm going to get back to you for monoclonal antibodies before we talk about this new CDC quarantine information.
Okay, great. Let's advance 2 slides then, I think. And maybe one more. I'm going to do this try to do this in 5 minutes. So many of you have heard that the FDA has approved 2 EUAs for monoclonal antibodies. These are neutralizing monoclonal antibodies. They help prevent progression of disease. They target the spike protein binding domain. And Eli Lilly got its EUA on November 9th and Regeneron on the 21st. And the the Lilly product is a single monoclonal antibody, whereas the Regeneron product is a cocktail of 2 separate antibodies. Let's go to the next slide. Briefly, I will say that these data are early phase data with small numbers, and that neither the trials were very impressive with regard to their primary endpoint, which was to look for decline in viral load. But what both of them noted was that specifically in highest risk patients, those over 65 and those with a BMI of over 35, that their rate of hospitalization or emergency room utilization was significantly lower in the treatment group than in the placebo group. And in this case, with the Lilly product, in the highest risk group, there was 4% ER or hospitalization utilization in the treatment group and 15% in the placebo group, a statistically significant difference. During that Lilly trial, there was one safety event of an anaphylaxis reaction. There were a couple milder infusion reactions. Let's go to the next slide. Similarly, the Regeneron product, we'll get there. This combination of these 2 monoclonal antibodies also showed that in a small number of people, like if you look at this N, it's 78 patients, treatment group had a lower risk of ER and hospital visits within 28 days, 3% in the treated group and 9% in the placebo group. And we're looking at a number needed to treat of about 10 to 12. Let's go to the next slide. So who's eligible for this? So this is specifically meant for outpatients. They've found that those later in the course of their COVID-19 disease fared more poorly if they were given these than not. And so this is meant to be given early in disease. So people have to be COVID test positive, they have to be symptomatic with classic COVID symptoms, and they have to be an adult or a child over 12 who have mild to moderate disease and are at increased risk, and that their symptoms have to be less than 10 days. It has to be less than 10 days since symptom onset. So they're trying to get to people early in the course of the disease, mild to moderate disease, but those people at high risk. And the people excluded, again, were people who are hospitalized, those requiring oxygen, or requiring those on chronic oxygen who required an increase over their baseline. Let's go to the next slide. It's administered as an IV infusion over an hour, and then the person has to be observed for an hour afterwards. So when you consider check-in and check-out, it's about a 3-hour period. It can only be administered where there's healthcare providers who have immediate access to treat the severe reactions and to to trigger EMS if there's a problem. Next slide. A lot of people have reservations about the use of this. The data is really poor, and so a lot of people have hesitated about recommending this. But more importantly, the logistics are very, very difficult because all of these patients are probably at their highest infectious rate. So you've got COVID positive people, and you're coming in for about 3 hours into a setting. So it can't be at a place where there are other patients. So it can't be at classic infusion centers where they're medically fragile people. And there have to be enough staff, and there have to be enough PPE. So logistically, hospitals, it's only going out to hospitals right now, but it will be expanded to other sources. Home care may be an ideal place for this. There are a lot of other issues as far as cost. And there are new monoclonals that will be coming that may offer additional advantages that may just be injectable and not an IV infusion. But one other factor to think about is that if you get a monoclonal antibody, does it interfere with your ability to receive the vaccine? And the answer is probably yes. And so if you're And so it may be a tough decision, or you may have to, we might have to get advice from ACIP about if someone's received a monoclonal antibody, then when can they get the vaccine afterwards? Let's go to the next slide. I won't talk about the allocation. Currently, it's going to hospitals and hospital systems, and they're trying to figure out where they can deliver this monoclonal antibody. And I think I'll stop there. That's my time.
Thank you, Dr. Sullivan. Just to say more on the allocation of monoclonal antibodies, right now our hospitals and health systems are really the only groups who have indicated the ability to have the infusion capabilities, but it is still really in limited use at this time, and we are doing a lot more exploration on this. So just wanted, it's not intended to stop there, and as we see more monoclonals, I think their application will become more easy. So with that, I want to make sure we get to the next topic, and I'm going to pass this off to Dr. Smits to talk about our CDC, or the new CDC quarantine guideline update.
Great. Thanks, Dr. Hargunani. Can you advance the slide? Thanks. So the CDC published yesterday a guideline to their quarantine. I'm sure a lot of you saw this in the news. The link on the slide there will take you directly to the CDC site where it kind of goes through the information I'm going to show you now. Just as a reminder, quarantine is when somebody has been exposed to COVID-19 but has not yet developed illness. And it's to help prevent them from spreading illness before they're symptomatic. Currently, the CDC, well, the CDC has always recommended a quarantine period of 14 days. If you read their website, they're actually still recommending a quarantine period of 14 days as the sort of gold standard that they would like to have followed if possible. But they acknowledge that there's a lot of difficulty with a 14-day quarantine and came up with two alternatives that could be used to shorten quarantine. The first is to quarantine 10 days, and if you develop no symptoms during that 10-day period, you can be out of quarantine without testing. They estimate that with this strategy, the post-quarantine transmission risk will be about 1%, although their range goes up to about 10%. Next slide, please. The second quarantine strategy that could be an alternative is a 7-day quarantine, and then if you have sufficient tests and you don't need them for symptomatic people, you do a test on day 5, 48 hours before the end of the quarantine, and if it's negative, release someone on day 7. With this strategy, they estimate the transmission risk is about 5%, or maybe up as high as 12% after the quarantine. In both cases, you have to continue symptom monitoring, masking, etc. Next slide, please. And so those are the sort of caveats to both of those newer, shorter quarantine guidelines. You cannot develop any symptoms. You have to have a daily monitoring of your symptoms, and then you need to counsel the person that they need to do all non-pharmaceutical interventions. That basically means wearing masks, social distancing, making sure they're washing hands, working remotely if possible, etc. Next slide. And then they also had a couple of footnotes. The second shortening strategy that involves that testing on day 5 should only be considered if you have adequate testing to do people who are symptomatic. That the people who are symptomatic should be given priority for testing rather than people trying to get out of quarantine. And then you also can continue that 14-day quarantine that is has the least risk of transmission and has the greatest experience at present. So they want you to know that they're not ending the 14-day quarantine, they're just offering 2 shorter alternatives. Next slide. So the rationale, if you look on the website, they do have a couple of peer-reviewed preprint articles that are basically modeling articles that they reference, but they're not available for review. So I'm not quite clear exactly how strong these models are or anything. But they kind of make it clear on their website that this is really a pragmatic change, that the longer quarantine periods result in some personal or financial hardship so that people aren't complying with them. It also it increases the burden on the public health system, trying to make sure that people are in quarantine for that long a time. And then the longer quarantines also they've been finding have been dissuading people from giving out their contacts because they don't want them to have the onerous 14-day quarantine. So the CDC's feeling is that if you're allowing something like a 7-day quarantine with that testing out option, it might be more acceptable to people. Next slide. So this is a little bit of a busy slide. It's from the CDC website. This is the modeling that they're showing about why the rationale is for these changes. So the smaller bit of the graph that's kind of in the upper right-hand corner is actually just the lower graph magnified so that you can see those little tiny things at the end between like day 10 and 12, or day 10 and 14 a little bit more. So this graph shows you if you are in quarantine and have no symptoms, what's your transmission risk? Day 0 is the day that you are supposedly infected or you are in contact with an infected person. So you can see it's a pretty high risk for those first 5 or 6 days. By day 7, the risk is coming down, and although it's still could be quite high with the no test kind of strategy, but it's kind of getting to an acceptable level with that negative test strategy. And then if you look out to about day 10, you're starting to get pretty low on the post-quarantine transmission risk, somewhat similar to day 14, although it's still significantly higher, particularly with the no test strategy. But this is the modeling that that's why they chose the 7-day with negative test and the 10-day without negative test as possibly reasonably safe alternatives.
Thanks, Ariel. Before you keep moving, I'm just going to pause for a couple questions. For Tom, maybe you could just tackle this based on what Ariel just outlined regarding the new CDC quarantine guidance change. Can you speak to what OHA is considering at this time in terms of OHA guidance?
Yeah, so we've been following this with interest for a couple weeks since we first heard that CDC might be considering such a change. So our senior health advisor team and our epidemiologists have been discussing this since it came out. We have made some recommendations to our leadership, but we don't have a final word yet. I will say that we think overall the CDC's recommendation is quite reasonable. And there are some concerns about specifically the test, inherent to the test-based strategy for discontinued quarantine in terms of testing capacity, equity concerns, since not everyone has equal access to testing, as well as practical concerns, just given the turnaround time that we're seeing for COVID tests in Oregon right now, which may be 3 or more days. So, the 7-day plus test doesn't necessarily reduce the duration of quarantine much over 10 days. And doesn't increase the burden on testing capacity. So we don't have a final word yet, but expect it very soon because we do realize this is quarantine is a large burden for a lot of people.
Great. And one other quick question that just came up, I can start with, and Dr. Jeanne, if you want to add to it. There's a question about how does this, quarantine recommendations after exposure to COVID-19 for the general population differ for the allowance of healthcare provider workers to continue working after exposure? And I can just say, one of the major differences in the consideration of some leniency for healthcare workers to continue to work after exposure is related to the PPE that they are that they are able to utilize in their healthcare encounters to diminish the risk of transmission or becoming ill. And also, particularly in recognition right now, due to the impacts of staff capacity on our hospital bed capacity, that we needed to have some ability for leniency if someone is asymptomatic and had good PPE when they were exposed. Dr. Jeanne, anything you wanted to add to that?
I would just emphasize, I think that's exactly right. Essential workers performing a highly essential frontline service here. They also have well-established standards and practices in terms of PPE, environmental cleaning, and ventilation that are above and beyond many other sectors. So I think it's in recognition of all those things.
And this is Ariel again. There was a question about using Binax now versus PCR. The CDC wants PCR. Binax now, I think, its sensitivity and specificity is too low. They specifically were talking about tests that take 2 days. So I'm assuming they all want all PCR tests.
Well, they did look at antigen as well, and they actually don't specifically say it has to be PCR. So basically any diagnostic test. So obviously not an antibody test, but an antigen test or a PCR test, molecular test would be okay. But they did show a higher rate of potential transmission if you are using an antigen test because of their lower sensitivity.
Great, thank you. So just one quick comment on one other question, and then I'm going to pass it to Dr. Smits just to close out with some brief information about Ms. A. So there was a question about how much the monoclonal antibodies costs. Currently, as was the case with remdesivir when it first had its EUA issued, the manufacturers of these two monoclonal antibodies are providing the therapies are working with the federal government to provide it to states free of charge at this time. So currently, as of just the last couple of weeks, we've been receiving the opportunity for having access to these therapies free of cost for the treatment itself. There is the allowance for billing for some of the administration costs, although that has been set at a quite low dollar amount per Medicare. We do not know how long the access to by states and hospitals for the free doses will continue. I anticipate at least through December, but we are waiting to hear more from the federal government. At some point, we anticipate this will move to become available on the commercial market like was remdesivir, and we have not yet heard what price the manufacturers plan to set these therapies at. So more information to come there. So Dr. Smits, just a couple words about Ms. A, and we can close out.
Great, thank you, Dana. Next, can you go forward probably 2 slides, Britt? Yep. Next slide. Thank you. So at our last talk a month ago, I had briefly mentioned this multisystem inflammatory syndrome in adults, and I promised that I would bring back more information. So that's basically what this is. Oh, actually, can you go back 1 slide, please? Yeah, perfect. So this is all in the MMWR from October 9th. And the citation, if you just go to the MMWR, you can read this in detail. This is a case series of 27 patients. The definition that the CDC has set for MIS A is very similar to the MIS C, which is the multisystem inflammatory syndrome in children. You have to have a severe hospitalization. You have to be over 21 rather than under 21, and you have to have some type of test showing that you have a SARS-CoV-2 infection, which could be PCR, antigen, or antibody test. And you have to have severe dysfunction in several different organ systems, lab evidence of severe inflammation, and absence of severe respiratory illness. So basically, you're not like having just multi-system organ failure from having your acute COVID. Next slide. So the patients in this case series were 21 to 50, and just to mention this, 26 of the 27 were in racial or ethnic minorities, so highly more represented in this case series than in the general population. The symptoms of MIS-A occurred 2 to 5 weeks after their preceding COVID symptoms, and of note, a third of the cases required antibody testing to identify that they'd had the SARS-CoV-2 infection. They had a series of different treatments. Most occurred intensive care and 3 died. So basically, just keep this in mind. If you see patients who've had a COVID infection and they're maybe a month out and they start to have some of these other symptoms and they're sick enough to be hospitalized, and just to let you know, this is the other group now that OHP has recommended coverage for. So for the antibody testing, just to clarify that. And that's it.
Great. So if you could move to the last slide, Britt, or the next one, there you go. Thank you all so much for listening in today. There will be another Project ECHO COVID-19 response for clinicians, the last of part 2 next week, this time. So we encourage you to chime in. We will hold our next general OHA COVID information webinar for healthcare providers on January 6th. And we'll be looking ahead to how we bring you this continued information on some routine basis. So please join us. Again, thank you for all the work that you're doing out there, and please reach out to us with any ongoing questions, and keep an eye on our website with updates. And thanks to my colleagues for sharing such great information today. Thank you all. Have a good day.